Hi, good evening, friends. So, today we are going to talk about survival analysis, and we have structured the session in such a format that in the first 30 minutes, I would be talking about what we did last time, and I will lay a foundation for survival analysis. So I will try to quickly go through the questions that we did last time or the assignment for last time. The first question was perform a simple logistic regression analysis to determine if there is a significant association between having more than 10 publications and having what is the number of children you had. So again, here the outcome variable was simple. It was having more than 10 publications. So there was no straightforward variable in the data set. What you needed to do was create another variable which had 0 for anyone who had less than 10 publications and 1 for anyone who has more than 10 or equal to 10 publications, and just do a logistic regression analysis by doing the command logistic more than 10 publications variable and the number of children variable. So it would just give the logistic if you named the second variable as pubcat or category of publications more than 10 or less than 10, and just regressed it with the number of children, it will give you the answer to this. The second question was, what may be the confounders in this association? So there are no hard and fast answer, clear answers to this. It was more for discussion purpose and make you think that what other variables present in the data set could affect both the publications and the number of children an individual may have had. So you could have thought about the designation of the individual, you could have thought about the gender of the individual, you could have thought about institution or country. So no answer is right or no answer is wrong. It all depends on how you present it, how you justify it, what logic you give for including or excluding a particular variable in this. The third question was perform a multiple logistic regression analysis by including your identified confounders and see if the association remains significant. So here you would have got one odds ratio for the number of children. You take a note of this odds ratio. This is the simple odds ratio or the crude odds ratio as we call it. And once you put in your confounders, whichever ones you choose, I chose age, sex, in addition to the number of children, which was the primary variable of interest, you will see that the number of children will have the same or a different odds ratio, and just need to compare if the odds ratio in the question 1 remained the same after adding your confounders. So this was a simple logistic regression in question 1, and in this question it was a multiple logistic regression because you added different other confounders or covariates. The next question was, could institution of work be associated with the number of publications? Obviously, some institutions have more pressure to publish, while others do not have as much pressure to publish. So obviously, the institution of work would be associated with the number of publications an individual may have. But the question to address was, how will you include the institution in a model? Now, obviously, we would see that institution is a categorical variable and there is no defined order of institution. There is nothing like one institution is better than the other, or there is a scale. So does anyone have any thoughts on how you could include institution into the model? Or did you discuss this, or did you have any ideas on how you could put the institution and compare to each other?
What I had one suggestion which I tried was that since there could be a difference between a teaching medical college and a private sector health institution, so just going by the name, which may have been inaccurate and incorrect also, tried to code it into a teaching and non-teaching institution, and I tried it. We could
Cool.
have tried a geographical kind of location also, but that I didn't have enough information for that.
Absolutely. So that would be one way to do it, that you use a teaching category versus a non-teaching category. Any other thoughts anyone has? So Yada says that code with a numerical value. Yes, I agree. You code every institute with a numerical value. But when you run a regression analysis, Yada, the problem that will come is it will read those, the software will read those codes as numbers. It will just give you the difference between one unit change of institution. So it will give you an odds ratio, which will be changing with every 1 unit change in institution. So, but we will have about 11 to 13 institutions, and then it will be difficult to interpret. How will you interpret that? There is no linearity, there is no association between the institutions, there is no scale, there is no grading. So it becomes difficult to address that. How else can you address this value of a institution into your logistic regression model? This is a common problem for any categorical variable which has got no inherent grading in itself and has more than 2 categories.
Nishant here. So I was thinking if this requires multinomial logistic regression instead of binomial.
But our dependent variable is only one. We are only interested in more than 10 publications or less
Okay.
than
Yeah.
10 publications. So we will stick to binomial regression. But the learning point or the teaching point in this exercise was that when you have more than 2 categories in one variable, and there is no defined order in these categories, these data has got an inherent command, which is the I dot command. So if you code the institutions, just like Iada had said, you give one separate or specific numerical code to each of the institutions. And you decide that any one of those particular institutions could be used as the baseline institution, and give that institution the code of 0. And when you then regress it using your previous command, that logistic publication category and I dot institute code. So if you had created a new variable and named it inst code, which is just a code number for each of the institutions, and when you run the command, you give it I dot institute code. So what Stata will do is now it will use your baseline category, which you have coded 0, and compare all the other institutions against the baseline category. So this will give you some idea or some reference point. It will use 0 as the reference category, 0 as the reference institution, and compare each of the other institutions with the 0 coded institution. So this is possible, or this is applicable to any categorical variable where you have no specific order or defined increment of 1, 2, 3, 4. This is a possible command that you could use in Stata and while running your analysis. Of course, one problem with the current data set was that some institutions had only 1 or 2 people. So there is no way that this data set was adequate to run this command. But the idea was to see that when you have a categorical data with no defined order, and you want to compare all the categories, you could use one of the categories as a base category and compare each one against this zero base category. Does that help, or does that make things clearer?
How would you, I mean, in this case, the 25 participants are from 21 different institutions. So in this case, that would be, I mean, it wouldn't make any sense in the end. Right?
Absolutely. It would be a horrible idea to do this in this data set. That's exactly what I said, because we don't have enough data points per institution. But it was only as a teaching exercise that you could just code it and it will compare against the baseline category. That's precisely, but this is a horrible idea for this particular data set. Yes, Dr. Asha.
Yeah, probably this kind of coding would be highly desirable. Let's say if there was one institution which was ranked number one in the country, and we had the number of publications from there, and then the rest, yes, as a gold standard, maybe we could have done.
Yes, or it's just about the institution, but it could be done for any other groupings where you want to compare one baseline with the other groups that you have, but you really don't know which, if there is any clear order between these groups or not.
Dr. Ashish, I
Yes.
thought the odds ratio had changed when I had added multiple variables, but the p-value was still significant. So how do I comment on this? The other variables were not significant, but the odds ratio had changed.
Yes, so the odds ratio will change between simple regression and multiple regression when you add other covariates or variables. If the change is less than 15%, it's taken as a rule of thumb that we don't pay much attention, and we say that the association is still holding strong. However, if between simple logistic regression and multiple logistic regression, the change is more than 15%, or if the direction changes completely, something which was significant now becomes insignificant, then we say that the added covariates, one of them or more of them, might be acting as either a confounder or as a mediator. Now, if it is a mediator based on the theory or between your understanding of the relationship, if you feel it is a mediator, then you report it as a mediator. Otherwise, this is one way to identify statistically that one of the variables is acting as a confounder.
Would this be like once we have added the other variables and rerun the logistic regression as a multiple logistic regression, now it's an adjusted odds ratio, correct?
Yes.
Which we are getting.
Yes.
So the
Yes.
adjusted odds ratio may well be different from a original unadjusted odds ratio.
Correct. But if the adjusted odds ratio is changing by more than 15%, then we say that confounding is happening.
Okay. Otherwise, we cannot comment on that. If it's less than 15%, but let's say the odds ratio has changed, even though it's less than 15%, and let's say the p-value also changes.
So if the direction of the p-value, I mean, if the p-value changes, that means the direction of the change is immense.
Okay.
So generally, that means your strength initially was not so robust that by adding just one variable, the change is less than 15%, but the direction of association has changed.
Okay.
Right. So
that we continue to rely on p-value.
Yes, we definitely will continue to rely on p-value or the confidence intervals. So our last question on this was, what is the interpretation of the odds ratio? So in the last model that I did, obviously I picked up from that, you might get different results. So obviously what we are trying to get is the odds ratio 1.2. It means for one unit change or for every year increase in age, it's 1.2 times the odds that there will be 1.2 times more publication than the previous age. For sex, it is 0.2. So in our data, our coding is that 0 is females and 1 is for males. So males have 0.2 times the odds of publishing as compared to females. So that is, I mean, there is no logic and there is no sense in this data. Don't bother about it. But this is what the coefficients or the odds ratios mean. Here you will see that age, it was a significant association. But here the confidence interval is across 1. It is crossing 1. So the association with sex was not significant. So much so for this. Now, if I
I have just one little question, Dr.
Yes.
If we could go back to the odds ratio.
Yes.
Odds ratio of 1.2 also means that there's a 20%, if we were to convert these into percentages higher or lower,
Yes.
then we can say it's a 20% higher chance or higher odds of publishing for every increase in age by a year, correct?
Yes. Yes.
Now, once this ratio is less than 1, let's say it is 0.2,
yes.
Then this means that there is a 20% lower chance or an 80% lower chance.
80% lower chance.
Less than 1, it will be 80% lower, and
Yes.
20 is the odds.
Yes.
Thank you.
Yeah. So here is a command which says generate a publication category equal to 0. Replace publication category equal to 1 if publications are greater than or equal to 10. Label variable publication category, in inverted commas, I have publications more than 10. So what it did was it generated a new variable, pubcat, which was 0. It replaced pubcat equal to 1 if there were more than or equal to 10 publications. And I just labeled this variable pubcat. So if I go to this and show you how pubcat is now, there are 10 people who have less than 10 publications, and there are 15 people who have 10 or more publications in the data set. This is how the data looks like now. And first I run this, that is logistic, pubcat, and children. So it tells me that anyone with one child increasing, there are 7 times the odds of having more than 10 publications. And this is significant. The p-value is 0.011. And the 95% confidence interval is very wide, obviously. 1 to 32 times it can be the odds. Now, what I was telling was I coded in the data countries. So we have 3 countries, India, Indonesia, and Sri Lanka. So if I show you the tab of the country, there are 3 countries, India, other, or 2. So there is one is Sri Lanka and 3 participants from Indonesia. So 2 was Indonesia. So this was how the table was set up. Now, if I want to compare, let's say, what is the publication against the baseline category of India, I recoded India as 0, Sri Lanka as 1, and Indonesia as 2. And while running the command, I told you we just need to put I dot the variable name. So I do logistic. My variable of outcome variable is pubcat. I run it against I dot country. Now this will not give us decent results here because, as I said, we have very few variables. I mean, we have very few observations. Sri Lanka has only 1 observation. But what it gives me is that it uses the baseline country and then compares each of the other categories, Indonesia or Sri Lanka, against the baseline India. So if you just need to put I dot and whatever be the categorical variable that you are using. The learning objectives which everybody should be taking home from this session. I believe if you are attending this workshop and today's session, you may or may not be able to run a survival analysis, but what you should definitely achieve is understand what is censoring. So there are several reasons why there might be censoring. In a nutshell, if I say that you are interested in one particular outcome, in some of the patients or in some of the individuals in your study, that outcome happens. When that happens, it's an uncensored data. But for some of the study participants, that event may not yet have happened, and you might have had to close the study. So you know that at this date, the event had not happened, but you don't know after that date if the event happened or not. One reason could be loss to follow. Second, you might have closed the study, or there may be n number of causes why you need to censor. But the only one line definition would be that you don't know whether the event has happened after a particular date, yes or no. That is just censoring, nothing more than that you need to know. It's important that we come out of designing research, which is cross-sectional studies. And most of our research goes not beyond t-test and chi-square test, because as clinicians, we refrain ourselves from going anywhere beyond. Once you start doing survival or time to event analysis in cohorts and longitudinal studies, your research will definitely increase in quality, substance, and will get better publication results. This is what I strongly feel. Like Dr. Rashmi just said, I would like you to take back from this session today, how do you set up your data for a longitudinal analysis? We will talk about the Stata commands. I also want everyone to understand what is a hazard by the end of today's session, at least if you have not gone through the previous videos. And you should know the interpretation of hazard ratios, Kaplan-Meier curves, and a Cox proportional hazards regression. So I'll go further from that. Censoring we dealt with. I'm not going to talk more about censoring. Now, how to set up your data. There are two ways to set up your data in the Excel sheet. Now you have longitudinal data. So just intuitively think that you are going to follow up this patient on more than one occasion. Dr. Suman, if I talk about patients undergoing dialysis, you could enroll this patient once his creatinine value crosses a particular limit, and then follow him up every month to see how many dialysis he's undergoing. But in
Yes.
any case, yes. So in any case, you would be having longitudinal data where one patient would be coming back again and again for repeated follow-ups. Again, coming back to Dr. Rashmi, there are two ways now I could set up this data. One, I could put a new row for every visit that this patient has. And I could have a column of creatinine, and I could enter the value of creatinine against each row. That is one way to do it. The second way to do it, I could have one patient in one row, and I could enter his creatinine values as creat 1, creat 2, creat 3, creat 4 with another column which has the date. So both ways you can set up the data, but the key variables that you need in your data for the software to understand, and this is true not only for Stata, but for any other software, to understand your data as longitudinal data, it needs to see three different variables. One is the ID variable or the identification variable. That means if your patient is coming for repeated recurrent visits, then there should be a column of identification which has got the same ID number for the patient every time he comes. And I could set this up by a patient Manoj. I could say that his creatinine on 10th February 2020 was 1.2. So I could label this date 1. I could label this creat 1. I could label this name. I could also insert another column here, and I could call this ID number, and I could give column Manoj, right? That's one way to do it. let's say this is my variable row, or the variable names are there in the first row. I'll increase the size of the screen so that it becomes easier for you to see. Right. Next time Manoj comes, I give him Manoj ID number 1. I may or may not have the name at that time. There may be mistakes in the name. Let's say he came on 24th February 2021, and he has a creatinine value of 1.5. So there are multiple rows for Manoj. The other way I could do it, I could put date 2 here and create 2 here, and I could just shift these and record it like this. I do not have another row for Manoj. So those are 2 ways I can set up this Excel sheet. Both are fine.
Yeah, I think this is what we are more familiar with.
So you can set it up any way. The software will recognize it. The important thing is you should have one ID variable in your data set. The next is the outcome event variable. Supposing we go back to this dummy data set that we were talking about. Here, I am intending, or my intention is to see how much is the time to hemodialysis once a patient crosses creatinine value of, let's say, 1. This is what I intended in this study. So here I will create an event column. Now this event for me could be hemodialysis. Hemodialysis would be 0 or 1. So that means on this date, so this has read it as date, I will have to change the setting of this column. This is 0 only, and this is not a date. So I will probably have to save, format this Excel sheet column and say that this is not a date, but a general number. We'll have to accept it as a number without any decimal places, and then it will start recognizing it as 0. Here my hemodialysis was 0, and my date of last visit was 24th February. So as of 24th February, his hemodialysis was 0. If I finish my study and stop seeing Manoj on 25th February, he is censored on 24th February with hemodialysis 0. However, there could be another patient who came to me on, let's say, 10 January 21, had a creatinine of, let's say, 11.2, and he underwent a hemodialysis when my event was 1. And I started following him up at some time. So this will become my event with 0 or 1. This column, I have to put in what is my event or the outcome, and I have to have zeros and ones in this column. So you said that if we don't have information about one patient, do we need to delete that entry, or can we keep that entry? That was a part of your question.
Yes.
So the whole exercise of building up survival analysis is this one key question, that we do not want to delete this individual whose information we do not have. The moment we delete him, we have lost whatever data we had on him maybe 10 days ago when he last visited us. So the entire Cox proportional hazards model or Kaplan-Meier analysis was built up to counter this problem, that we don't want to lose his information. We want to get, or we want to utilize as much from this particular information as much as we can. Yes, we don't know what happened to him after follow-up, but we do know what happened to him before follow-up. So we want to capture as much information as we can from whatever is available.
So that, correct me if I'm wrong, in my understanding, that means that, let's say my study period was meant to be 3 months for every patient, starting onwards of enrollment. Now, one patient I was able to observe only for 1 month. After that, I lost him to follow-up, but he was alive at that time. So I put his event as, let's say, present 1. I was looking
No.
for survival.
No.
Okay.
So you are, so most of your survival analysis, or if your event of interest is death,
Yeah,
you
then
will
that will be 1.
zero. Then it will be 0. That the event did not occur. The death did not happen at 1 month.
Okay, so my event, I'm looking for mortality, that is death. If it happens, I put it as 1. If it does not happen, I put it as 0, correct?
Period. Absolutely correct.
Okay, now I don't know what happened the rest of the 2 months. So does that mean this patient is still going to be included in that analysis?
Absolutely, yes.
And my results will not speak of this lack of complete follow-up at any stage? Or do I need to put in that, okay, so many patients, the data was censored?
Absolutely not. You will, this patient's data of 1 month is crucial. It's important for you. You want to include this in your analysis. And that is why you have censored him at 1 month. And you want that 1 month observation period to form your denominator.
Okay, but then maybe in the results section, I am forced to commit that how many patients were lost to follow-up, and hence the data is like for whatever time period.
Yes, you do that as a flowchart of the study or in somewhere, but even that is not mandatory. And that is, I mean, you obviously want to show how much follow-up you have, but for a dynamic cohort, every day of follow-up counts and contributes to the denominator in the number of follow-up days period.
Okay, is that why we also have to talk about a person year all the
Exactly,
time?
precisely.
That is where it will reflect probably if I've
Precisely.
got to follow up somewhere.
Yes.
Okay.
You will be clearer on this once we finish the exercises for today's session also.
Thank you.
Right. So those were 2 points. Now, I hope that everyone is clear on those 2. Your data should have an identification variable. Your data should have an outcome event variable. The third important variable that your data should have is your time variable. You need to know when the event occurred and how much time your patient is contributing to your follow-up period. For example, let's say that the date 1 for this second patient, let's call him, let's say Rahim, for whatever reason. We have an ID number 2 on this patient. He came to us for the first time, let's say on 5th January 2005. And he had a creatinine at that time of 1.4 when we recruited him in our study. And he first time presented on 10th January 21 when his creatinine was 11.2. Here we need to have a time variable. Now this time variable you can compute in your Excel sheet by putting a formula, which could be this minus this. I hope it works. Yes. So it is giving me 380 days. I just copy this and paste it into the other column. This patient is contributing 5,849 days, whereas this patient contributed 380 days. So if you have this time, I hope everyone understood how this time came. It was just this date minus this date. So this was the entire period of follow-up that was contributed by this patient. And this date minus this date was what was contributed by this patient. So now I have got 3 important variables. One is the time variable, the event variable, whether hemodialysis was done or not, and the ID variable. So if your data set has got these 3 variables, then you can easily run a survival time analysis on your data. That is how you just need to set up your data set. Dr. Saurabh says, should we put outcome variable after every visit? If you put it again and again, it doesn't matter. It's about when you're analyzing finally, that's when you really need to put it. And that's when you will analyze it finally. So this is all that I had for setting up your data. Once you have done this, it's easy to set up your data set with a command called stset. That means ST is for survival time Stata recognizes this as st set. That means you want to set your data as a survival time data. Another command is stdes, that is survival time describe. That means you want to describe your survival time data. Another command is STIR or stir, which is survival time incidence rate. If you just give STIR, it will just give you incidence rates quickly. One is STS graph, that will just draw the Kaplan-Meier curve without any other. I mean, all these commands are complete in themselves. If you just put exactly these commands, they will run without any variables. So once your data is set, it will just run these commands. And then there is the ST-Cox, which is the Cox regression analysis. We will see more about them subsequently. Incidence rate was another thing that was talked about in John's videos. Incidence rate is nothing but the number of events divided by the duration of time. Incidence rate ratio is nothing but incidence rate in group 1 divided by incidence rate in group 2 if you are looking to analyze or compare rates in two different groups. The hazard function is another thing that I would like everyone to carry back from today's session. If you give me 1 minute of your attention, 100% attention, I will try and make this clear to you. So the hazard function is also called H, is just the probability of having an event in a time interval. So imagine that you are studying very small multiple time intervals in a data set. Hazard defines or describes what is the probability of having an event in a particular interval. Obviously, to have death in that particular interval, the death must not have happened before then. So the person must have been alive when this time interval began. So the numerator becomes, it is the probability of having an event in an interval given that the person has survived until this particular interval, and you divide it by the length of the interval. It's not rocket science. It's not complicated. It's again repeating, it's the probability of having an event in an interval, obviously because he survived until that interval, divided by the length of time. If you're clear with that, the next is the survival function. What we talked about was the hazard function. Remember, hazard is H. Survival function is 1 minus H. So obviously, it is probability of surviving in a particular interval. Obviously, if he has survived till then, till the beginning of the interval, what is the probability that the individual will survive this entire interval? That is called the survival function, which is also called 1 minus H. These terms are confusing, but if you just remember this, not very difficult. Hazard function, probability of having the event in the interval. Survival function, probability of surviving in that interval, period. Kaplan-Meier curves, we will see them. And coming to Cox proportional hazards, I have killed Dr. Amir's time completely, and I will owe him an apology for this. If you remember the basic regression equation, y is equal to beta naught plus beta 1 x1, where beta naught is a constant. We are rarely, if ever, interested in beta naught. The entire exercise we do is to try and find out this beta 1. That was the basic regression equation. For Cox proportional hazards, what is y? This is just the time to event or the survival time analysis. That becomes our y. And when we reframe this equation, it's the same equation. Here, y is going to be replaced by something, beta naught is going to be replaced by something, and beta 1 x1 is going to be replaced by something. Do not get bothered by the big terms that are there. Just look at this equation, and this is your y, which is your outcome variable. This is the beta naught which we had, which we are never interested in. Here also, we are never going to be interested in this beta naught. The entire exercise will be to calculate this beta 1, which is the coefficient which will indicate the change in your outcome variable with 1 unit change in x, period. There is nothing more, nothing beyond this to remember. What we have, if you look at this previous equation, what we have here is what is called the hazard. It's just a mathematical connotation. Don't bother about it, read it as hazard. So if you read it as hazard, what you have is that the log of the hazard is log of that constant term which was here, which is and beta 1 x1. The rest of the things remain same. Obviously, if you have log of the hazard, you would want to take the anti-log to find the exact hazard ratio that you are interested in. The anti-log is also called the exponentiation. So when you look at hazard, it becomes hazard. Again, this k is something which we are not interested in. And this is exponential of beta 1 x1. And like I said, this beta 1 is all that we are interested to find out. That is nothing but your Cox proportional hazards. Please don't get bothered by the equations. It is all the effort to find that beta 1 which remains same, whether you are doing a linear regression or a logistic regression or a Cox proportional hazards regression model. The entire exercise is around that interpretation of beta 1.
I think Dr. Ashish has wonderfully explained a lot of things regarding logistic regression and survival analysis. What we can do is, the first thing is that there were some questions, and I thought I will just one point I would like to mention regarding the points that were put up, that if you change the if you for missing values you put some other value, then odds ratio gets changed, or some other things if you change, then also there is a change in the p value or odds ratio. When you add more variables, again there is a change in p value, odds ratios. So it's all a game of input and output. As the input will go on changing, the output will go on changing, and all the outputs are important if your inputs are important. So, and how you decide on your inputs will depend upon the background knowledge, the logic behind that phenomenon that you are studying, and then whatever output will come out from the data analysis will be accepted and respected. So you all have got the data with you, and you might have practiced also with the data, because as John McGrady will be joining, so he will be discussing about various interpretations of and other aspects of the survival analysis. We should know about this particular thing that yes, Dr. Asha, please.
Yeah, hi, Dr. Amir. I'm a little confused. I just want to clarify that when we say it is a Cox regression, does it compulsorily have to look for mortality and not survival as the outcome?
No.
So
It's not
survival. So if if I'm using Cox regression to look for survival, I will code survival as 1.
Yes, very true.
And that is the same as a survival analysis then.
Yes, the survival analysis is a very broad umbrella term. It involves many things. One of the things is Cox regression analysis,
The other would be a KM.
log rank test, uh, Kaplan-Meier curve is just a visualization of the whole thing going on.
Yes, but I could use that too.
Yes, definitely. Survival analysis is a broad term. Under that, there are many things going on. One of them is the regression analysis. And in that, if the outcome of interest is survival, you code that one. If it is death, you code that as one. That is perfect.
Okay, thank you.
Hi, John. Welcome. Thank you
Good
for
afternoon,
joining us.
everyone. Good afternoon, evening. Hi, greetings from Baltimore, where it's the morning. I'm joined by my cat here. She may jump in at any point, so my apologies. She's a big Zoom fan, so you may hear her. Yes, I'm sorry, just not to interrupt, Ashish, but yes, it's on some of this terminology is unfortunately pigeonholes the analysis sort of verbally, and survival analysis, sometimes more generally called time to event analysis, can be used in a situation where we have a cohort study where there's a defined starting point for everyone in the study, where everyone in the study has not had the event of interest. So certainly if survival or mortality, depending on how you characterize it, is the outcome, everybody is alive at the start of the study. But this can be time to quitting smoking for a bunch of people who are current smokers at time zero. This can be time to completing a PhD degree for people who have enrolled in a program. This can be time to going to remission for people with a particular cancer. I have some thoughts that I'd like to just note as a follow-up that I sort of promised in the videos, but I'd prefer to defer to your questions first, so please.
I had a specific question about proportional hazards analysis. And when you were talking about it, you mentioned that the hazard ratio is assumed to be constant in that model. So is that something that we need to check? For example, specifically when you were showing the child mortality rates from Nepal, the Kaplan-Meier curves, although they were clearly separated, they all looked like they were the same shape. Is that important? Like if one of the curves were straight instead of a curve, would that mean that the hazards may not be proportional?
Excellent question, and thank you for bringing that up. That's one of the things I do want to discuss in a little more detail now that many of you have had a chance to sort of think about this. So thank you, Nishad. I'm going to share my screen if that's okay with everyone. So the question about proportional hazards is a good one. What the proportional hazards assumption is actually by the time we see a survival curve, we're seeing this assumption transformed several times. So the actual assumption can either be expressed on the scale that the regression is estimated on, which is the log hazard, and hazard's just a synonym for risk, really, or if we exponentiate that to the hazard or risk scale, which is a reverse transformation of survival. As you may recall, if you've gotten to that section on how Cox regression can be used to estimate corresponding survival curves, there's this complicated transformation from the log hazard scale to the survival scale, but there is a one-to-one transformation. But the assumption is on, if you were to look at it on the regression scale, it's that any two groups that we compare, regardless of the baseline shape of the risk over time, that the difference in the log risk is consistent over time. If we were to graph two group curves over time, these curves and their difference is estimated under assumption that the difference is constant on this log hazard scale. If you were to exponentiate this to the hazard scale, where the phrase proportional hazard comes in, is just these exponentiated curves, they would not have a constant difference, but they'd be in a, and I'm going to do a terrible job of drawing this, in a constant ratio. So if, for example, group A compared to B has twice the hazard at 2 weeks of group B, the assumption is, and the estimate is based on the assumption that this ratio is 2 to 1 at 30 weeks or at 15 weeks, etc. Does that make sense? So it's a pretty strong assumption, right? It assumes that the relative hazard of our time to event outcome is always in one direction for two groups being compared in the same ratio or on the log scale, the same difference. So when these things are transformed to survival curves, what we'd expect to see is the easiest way to get a sense of whether or not the proportional hazards assumption is met by looking at survival curve estimates is if the two curves generally separate consistently, so one curve consistently has better survival than the other, then that is a necessary condition for proportional hazards. What's not clear, though, from the survival curves is the difference between the curves does not need to be consistent for proportional hazards to be met, because the assumption is on a back transferred scale, several layers removed, if that makes any sense. If you were to see, however, survival curves that cross over dramatically, something like this, across the follow-up period, that would indicate a violation of the proportional hazard assumption, because in the first part of the follow-up period, the survival in the first group A is superior to the survival in group B, indicating that the hazard in group B is higher than that of group A in the first part of the survival period, but in the second part, the direction changes. So there are, if we had time to do model assumption diagnostics, there are ways to get a visual on these graphics to do a subjective assessment of proportionality in meeting that assumption. And there are formal tests that can be run. But you might be thinking, John, this is a big assumption, and it is. How come Cox is the gold is the thing that seems to always be used in clinical research when there have to be situations where this isn't met? Any thoughts on that? So here's what, Nishad, this is what usually happens, quite frankly, is these diagnostics can be done, and if there's a clear violation, then sometimes what's done is the analysis period is split into two different sections and separate results are estimated for each period. In many situations, the reality is, while there isn't proportional hazards per se, one group always tends to do better or worse than the other group. So you may have a situation more realistically. In many situations, you have something like this. On the actual log hazard scale, you might have a group that looks like this, and a second group that looks like this. I'm making this up, but where the difference isn't exactly constant, and hence the resulting ratio of hazards isn't perfectly constant across the entire time period, but the hazard is always higher for one group compared to the other. So it follows, the risk always goes in the same direction regardless of time, just not by the same difference on that log scale or the same ratio when exponentiated to the risk scale. And so that technically violates proportional hazards, but what Cox ends up doing with this is what we get essentially is a weighted average of these differences over time, a weighted average into one regression slope or a log hazard ratio, which can then be, exponentiated to get that ratio. And that ratio is just a weighted average of the higher risk in group B compared to A across that time frame. So it's not a, so it's not a horrific thing, even though the assumption is technically violated.
Thank you.
There is another question that I see in the chat box from Venkat, who asks why the step happens only when an event occurs. I believe he's referring to the Kaplan-Meier curves and not during a censoring event. John, all yours.
Well, so if we are looking, just think of it this way. Apologies, who asked the question? The name, I'm sorry.
Venkat. Hi, hi, sir.
Nice to meet you. Sorry, I just wanted to be able to address you by name. Thank you for the question. So why can we only estimate change in survival when an event occurs? That's a great question. Let's take it back to a fundamental sort of stripping down of what we have going on here, and let's say we're only looking at one time bin.
Sorry for the interruption.
Please go ahead.
My question is, during an event, the probability changes, but even during censoring event, the number at risk changes.
Correct.
So the step should happen not only during an event, but also during a censoring. But doesn't happen the way in Kaplan-Meier. So why it doesn't happen why there is no step during a censoring event? That's me.
Well, good question, but think of it this way, Venkat. So you're right. So let's just think of, okay, so we have a situation here. Here's the time. Let's suppose there's 10 people at risk and one person has the event, right? So the number at risk at that time is 10. These are all the people being followed who are still being followed at this time point. And the time-specific survival is 9 out of 10. 9 out of 10 of the people who are still being followed, 9 out of 10 of the people who are still at risk move forward beyond that, survive beyond. And then we get to the, let's say the next point is the censoring, right? Right up until that point, 9 people are still being followed. And then when a person is censored, we lose one person, and our at-risk pool moving forward is now 8 instead of 9 because we've lost information about this person who was censored at, say, 11 months or whatever this time is. But at that time, it's true, our information about who's at risk changes, but nothing has occurred there that we know of in terms of our event outcome. So this person drops out of those who are being followed and are still considered risk of having the event, whether it be dying, quitting smoking, completing the PhD, whatever the case may be. They drop out without having had that event. And all we know about them is they made it 11 months and didn't have the event. So they were in our risk pool until they dropped out, but nothing happened at 11 months in terms of the outcome. So we can't, the Kaplan-Meier and these other methods say, look, no information about the event is no information. We're not going to assume it occurred or that it occurred a month later and base our survival estimates based on that. All we know about this person is he or she was part of the pool of people at risk until they dropped out. So I'm not sure, I'm hoping that answers your question, but essentially the curve doesn't change because the curve is tracking the proportion, something about the likelihood of having had the event. And if there's no event, when this person drops out, there's no change in the likelihood of having an event, even though we've lost one person to follow up.
Thank you, Doctor.
We have another question from Aditya Perdana. Aditya is from Sri Lanka, and he asks, can we use a Kaplan-Meier curve to assess time to event when the event of interest is treatment response?
Fantastic question, Perdana. Yes, absolutely. So if we're interested in, let's just do it very quickly, just talk about a toy example of that. But yes, absolutely. And in fact, this is for things like cancer studies where we have patients, right? Patients with cancer, active cancer, for example, a clinical trial time 0, they may be randomized to a new experimental treatment or control group, and the control group may be no treatment, or it may be the standard chemotherapy used for, et cetera, if that makes sense. And so the question of interest is we're looking at, I guess, remission, which would be response to treatment. And we're hoping that the risk of the outcome, we're hoping that the risk, and it sounds strange, but it's absolutely correct. It just sounds strange in the way we colloquially use the word risk, but technically it's correct. The hope is that the risk of remission or treatment response is higher with the experimental treatment, right? And so what we have here is people who start at randomization, whether they're randomized to the experimental treatment or the current standard of care, and they're followed up to a certain amount of time until they go into remission. In other words, respond to treatment or until they're censored. So absolutely, response to treatment, when, especially in situations, in many situations, it could be done if everybody ultimately responded, but in many situations, unfortunately, there is a percentage of people who don't respond over the follow-up period and either aren't followed for the full potential length because they are enrolled later or drop out, or make it to the end of the study without. Does that make sense?
Yeah, thank you, John. So
Sure,
in short, yes, we can use it for treatment outcomes also. Now there's another question from Asha, and this is, if there is a different interpretation from p-value and 95% confidence intervals, which one should dictate the interpretation? Let me ask it in a different manner or in a different wording. I have never seen that the p-value and the confidence interval gives a different interpretation. Does it happen in your experience? And how do we then interpret it?
So generally speaking, no, they concur with each other in the overall message. It's just that there's more information to work with, in my opinion, in the confidence interval. But generally speaking, if the confidence interval excludes the null value, which would mean no association between the outcome and the comparison we're making, treatment to control, etc. If it excludes that, then the resulting p-value will be consistent with that and reject that null hypothesis of no association in favor of the alternative. Is that what you are getting at? So I just want to make sure.
So basically, I think she's trying to ask that if there is a discrepancy between the interpretation of the p-value and the confidence interval, which one do we choose?
I would say that generally speaking, there are rare situations where there's a slight discrepancy, but generally speaking, they will concur. In situations where there's a slight discrepancy, let's say we've got a p-value of, and this can happen very rarely, but it can happen when your results are right around the null value, just circulating around them. So you can have situations where, say, your p-value is slightly greater than the cutoff of 0.05, maybe it's 0.055, which is technically not statistically significant. And your confidence interval, say, let's just say for a hazard ratio, technically doesn't include the null value of 1. This can happen very rarely, but it has to do with slight mechanical breakdowns in both procedures. Generally speaking, I wouldn't worry about this. kind of discrepancy, but people make a big deal out of this because they don't know what to do. But I personally, from a scientific perspective, I don't think it matters that much, quite frankly, because what we've seen here in this confidence interval, if all you're trying to do is determine statistical significance, then it really doesn't answer a deeper scientific question, in my opinion. And yes, technically a p-value of 0.055 is not statistically significant, and technically a confidence interval for hazard ratio that doesn't include 1 is, but what kind of inference can you make scientifically from a confidence interval like this? There's still an incredible amount of scientific ambiguity. So I don't, in situations like this, the scientific conclusion is still murky and ambiguous. So I don't think there's any real conflict there, in my opinion. I mean, I think if all you want to do is call something statistically significant, which I know none of you were thinking is the end goal, but if all you want to do is call it significant, then you would favor these results. But saying it's statistically significant versus not doesn't add much to the story anyway, regardless of whether there's a discrepancy or not. That's my opinion. Does that make sense? P-value is useful for making sweeping decisions when you have a lot of things to look at, but pardon my coughing, but this is my sort of take on hypothesis testing versus confidence intervals, regardless of the methodology and regardless of the just regardless of the methodology. So more generically, if I always think of it like this. So Dr. Ashtayagi, and I apologize if I mispronounce your name, but think about it like this. If I tell you I did a clinical trial comparing an outcome between a treatment and a control group, let's think of it, let's take it out of, let's just go for something more guttural for a minute. Suppose, Dr. Ashtayagi, I asked you, hey, why don't you come work for me? Come work for me. Your working conditions will be exactly the same. Your job responsibilities are exactly the same. You don't need to move. You can work remotely. And I will pay you something different than you make now. Silly example, but let's assume everything else is the same. And I know I'm not suggesting you're motivated by money. I'm boiling this down very, very basic example. What would you want to know if everything looked good about what I'm offering you? It was the same thing, and I promised to pay you something different than your current salary. What would you want to know?
Is it worth it? That's
right.
what I'd like to know.
Right. And by is it worth it, what do you mean?
I mean, is it significantly better?
Right. Because it could also be what?
Because it could boil down to no significant difference.
I could be paying you less, as a matter of fact, right?
Yeah.
So this is not a lot of information, is it?
Okay.
So if I said to you, now I'll give you some information on how much more or less I'll pay you, I'll give you a range, that might be helpful in making the decision. Would you agree?
Agreed.
So this is the decision you would get from just a p-value.
Okay.
Does that make sense?
Got it. Yeah.
And if you look at the confidence interval, that's going to inform you about whether it's worth it or not, right?
Right. And I asked this question, John, because in one of the several examples in your videos, there was one particular variable which such a discrepancy was showing up. So that's when I had thought what would be wiser to choose from. And from your
very good question.
It appears it should be our confidence interval. One more thing.
If you're simply making a decision about is this statistically significant or not, choose the one that favors your result. it doesn't really matter. But if you're simply making that decision, it's either to weed out potential predictors from a large lot of them,
Yeah.
in which case this one, there's ambiguity anyway,
Hmm.
or you're taking a surface level approach to science. And I'm not dogging you out here. I'm just saying that if your only criteria for inclusion otherwise is whether it's statistically significant or not, this is the decision you're making and you're not taking into account this. Does that make sense?
Yeah, or maybe it would be just wise to kind of agree to the ambiguity and look for a clinical reason and say that it's not such a strong association.
Absolutely. I mean, it really depends on, you're in the driver's seat, right? So you could say, let's suppose we had I mean, let's play this scenario out. Let's just give a couple different scenarios. In one scenario, my hazard ratio of interest comparing treatment to control, and of course you have to evaluate as to what two groups are being compared here. And it could be something for a 1 unit difference on some interval scale for age and years or something as well. But suppose the estimated hazard ratio is 0.97 with a confidence interval of 0.95 to 0.998 or something like that. And P is equal to 0.055, you know, that example. Compare that to a situation like this, where the estimated hazard ratio is 0.81 with a 0.68. I'm just making these numbers up. You know, if this was treatment to control, obviously we'd have to consider what two groups are being compared. But suppose this was a new treatment versus an old. You know, there might be some scientific ambiguity here, regardless of statistical significance or not, because this estimated reduction in the hazard of 3% may not be, even if this were the truth, it may or may not be enough to disrupt the delivery mechanisms in place. There may be cost issues, there may be side effects that, you know, that are not, you know, all that has to be weighed in. And in this scenario, the observed reduction is a lot more substantial, even though there's similar ambiguity about the result at the population level. You know, this might be something here that spurs somebody else to take on further research in a higher powered study, et cetera, whereas this one might be left on the table. I'm just, you know, there's not one perfect answer, but does that make any sense?
Yeah, thank you. Thank you, John.
So the question is, in the case about, are there other, good question. So when we look at a simple Kaplan-Meier comparison, Risha, for say, suppose we have you know, an observational study and we're looking at the impact of okay, so treatment affecting response. Okay, so we could look at this in two ways. Let's talk about, and this is a deeper not rabbit hole, because but I didn't discuss this in my lectures just because of the scope of things. But you're asking a great question. I think you're asking, and correct me otherwise, Risha, but you know, if I have a treatment that is, on the whole, perhaps it looks beneficial. So time to remission. And on the whole, it looks beneficial. If I look at the entire sample, all I'm going to be able to ascertain here is whether it's beneficial or not for everyone taken together. What I think you're asking about, and please correct me if I'm wrong, is you might be interested in saying, well, yes, if I had to make a recommendation right here, right now, and this is all I had, the treatment is favorable, right? Maybe the hazard ratio of remission. I'm sorry, if this is time to remission, right? Then we would want it to look like this. I'm sorry, control would be up here and the treatment would be here, because we'd want more remission, correct? or treatment effect. So maybe the hazard ratio for the treatment to control is 1.5, 50% greater chance of response to treatment in the follow-up period for those with the experimental treatment. This is estimated based on everyone in the study, but what you might be asking, Risha, I think, and tell me if I'm wrong, is, well, I see a lot of, maybe this sample was disproportionately or because of younger, because survival, in this cancer is also associated with age, and maybe the clinical trial enrolled disproportionately younger persons, right? But maybe I want to look at this same result separately for those who are over a certain threshold versus, because I know that older persons with cancer don't tolerate harsh treatments as well. I'm just, and so I want to look at these results again separately for those who are older versus those who are younger. Is that correct? Yeah. The only way to ascertain whether or not the treatment association was different for different subgroups of patients based on other characteristics would be to do subsequent subgroup analyses. In the overall Kaplan-Meier, it wouldn't be necessarily evident. Does that make sense?
Yes, sir.
Great. Now that brings up something that I didn't show you in the scope of Cox regression, and you probably didn't see with linear logistic, but those models can be extended so that I could estimate and get confidence intervals, separate hazard ratios, for example, of treatment to control for different subgroups, and could formally statistically test whether those associations were different as well. So all of this can be done with extensions to what we've talked about.
Okay, so any limitations for this curve in the populations like this you mentioned we can do further? Otherwise, any other limitations?
Well, the curve, I don't think of it as a limitation of the curve. It's this. It can analyze things at the scope the study is set out to do. Does that make sense? So a limitation would be missing this, but that's on the researcher's side. That's not, I guess I don't think of that as a fault of the curve of the methodology itself. The methodology is dumb. We are the smart part, and I don't mean this pejoratively, but the methodology can only do what we ask it to do. Does that make sense?
Yes, sir. That's really helpful. Thank you.
So let me ask you, John, are there different kinds of Kaplan-Meier curves? Can we have, the same term Kaplan-Meier, which is used for showing a survival analysis or for a probability function or showing cumulative incidence function? Are there different ones we could draw?
So the Kaplan-Meier curve is simply one take on estimating the survival curve. It's one approach. Another approach is taking the Cox regression approach, which estimates the association on the log hazard scale under the assumption of proportional hazards. And as we've shown, and maybe some of you may have not gotten to yet, but it can actually go be translated back to a survival curve estimate as well. And that's another approach to estimating survival over time, whose methodology is slightly different. So the Kaplan-Meier is just a brand, if that makes sense, a way of doing this. And we can present survival curves, whether they're estimated by Kaplan-Meier or not, either as survival curves or their complement, which would be cumulative incidence. But they're both estimated the same way. Does that make sense, Ashish?
Yeah, thank you, John. So we have one question from Venkat, who's trying to grapple intuitively with the idea of hazards ratio. And he says, how do we interpret hazards ratio? Does
Very
it
good question.
sound like odds ratio or risk ratio?
Right. I mean, it really is. The thing that makes it different, whenever you invoke the word hazard, the implication is that there's a time element. If you're an epidemiologist, whenever you invoke the word risk, there's an implication that there's a time element, although we sometimes treat the time element as the entire follow-up period. Technically, the difference between risk and hazard is that risk is calculated over some discretization of time, like in 1 week intervals or 1 year intervals or 1 day intervals. And as you shrink that window of time into finer, per second or per, you get a finer tuned estimate of time specific risk. As this interval converges to milliseconds or instantaneous, that's when we have what technically is a hazard. The hazard is the risk of an outcome in a very small period of time. That being said, for all intents and purposes, risk ratios and hazard ratios can be interpreted the same way.
Thank you, sir. Thank you.
And I really, it's an unfortunate, in some ways, disservice that, one of the things I say about statistics all the time is, if we didn't keep changing the terminology, right, I'd be out of a job, right? Because it really is more of the same thing, but we just change it enough to make it sound different. But for all intents and purposes, a hazard ratio is a relative risk. And that's how you should be thinking about it in terms of making scientific extensions.
Yes, thank you, sir. It's very clear.
So a follow-up question on that comes from Dr. Asha, who's asking, would it be better to change the words odds or hazards and just use the word chance?
You could call it a chance ratio. I think, so there is while I don't want to belabor the point here, this is one of the difficulties in communicating epidemiological concepts is colloquially we use the words, so there's, synonyms here. Risk and hazard are synonyms. Odds is related to risk, but it is not a synonym for risk. It is a function of risk. So colloquially, if you and I were talking about anything that had a probability component, whether it be weather, sports, winning the lottery, or medicine, right? We might colloquially interchange the words odds and risk, because they're sort of used in common speaking terms the same way, but they are not exactly the same thing. And in fact, the odds and then the odds ratio is, in terms of clarity, is second tier to risk and risk ratio. So the question is, why do we even bother with odds if we could estimate risk? And the answer is A, because as Marie showed you, the first measure of association one gets at face value from a computer with logistic regression is in terms of odds and odds ratios. Even if we're not constrained to those as measures of association, that's the first representation of comparisons you will get because of the mathematics behind logistic regression. Now, if we have study in which we can properly estimate risk, then we can also, with a little bit of painful work, even with a computer, we can estimate aspects on the risk scale from logistic regression and get relative risk, et cetera. But there's another reason why odds are used, and I don't want to belabor it here because it's obviously not germane to what I'm talking about, which are prospective cohort studies. But there is one type of study that's oft used in epidemiology for rare event outcomes when we're one to do a prospective study and follow a cohort of persons to see whether an event occurs or not in a fixed time period. One would need so many enrollees just to actually incur any events. There's something in epidemiology called a case control study. And I won't go into details here, but in this particular study, the only measure of association that can be validly and illegally estimated from the data is an odds ratio. And in that one situation there, there's, that's the only way we can quantify with risk comparisons. Does that make any sense? So these two things, risk and hazard, you could probably also substitute probability or chance and call them chance ratios. And that would work for me, but the rest of the world hasn't caught up with us.
Right. No, thank you, John. Actually, my question was just regarding when we get our results from statistical analysis, all these are definitive terms with definite connotations to them. But when I'm trying to interpret my results as a clinician, would it be wrong to just kind of say that the chance is that is what I wanted to know? Would that
No,
be
that's fine. That makes perfect sense. Absolutely. There's a higher
okay,
chance.
That was my only question.
Group, right?
Yeah.
No, that's fine.
Yeah. Okay, because it's easier for me intuitively as a clinician to understand that. That is all.
Perfect. So there's
you.
a higher chance of recovery for people on treatment. There's a higher chance of mortality for people who have high cholesterol. However, is that what you mean?
Right.
Yeah. Perfect.
Yeah, that's what I meant. Thank you.
Why don't you go ahead and ask your other question on the ROC analysis, because I know already I have done a messy job on answering that.
Okay, no. John, supposing I have a continuous predictor and a binary outcome, then instead of a simple Cox regression, can I also do an ROC analysis? Or, can they substitute for each other if I'm not interested in a definitive cutoff value of the predictor?
Well, good question. So ROC analysis, with a Cox regression, what it could be, you can do a time-specific ROC. Does that make sense? So you can look at any time in the follow-up period, usually, by the end of the follow-up period, but
yeah, to
look at the binary outcome at that given time. Does that make sense? Since it's like a logistic regression where things change over time, right? Okay. So you could look at how well how well, let's say you used a new diagnostic for detecting in a hospital. What's your area of interest?
Mine, critical care.
Critical care. So you've got somebody who comes into the ICU, right? Does that sound correct? Okay. And absolutely. You want say, oh, go ahead. I'm sorry.
No, correct.
So let's say you probably, so they're in the ICU and you want to look at something like, and excuse my dumbing down of something that's way more complicated and you were an expert about it and I'm not, but suppose you want to look at people who are not in shock when they are admitted and you want to look at some diagnostic for predicting whether they will experience shock during their first 24 hours in the ICU or something like that. Does that sound like a kind of thing you might be interested in?
Yeah, sure.
Okay, great. So maybe you're monitoring something about them continuously over that time period, like their heart rate or something. I'm going to, again, I'm not an expert, so forgive me if this isn't perfectly clinically relevant, but let's say you're measuring their heart rate every sort of discretely every 15 minutes while they're in the ICU. You know, it's being picked up by a monitor and you can get a time series of that. And let's say you want to see how predictive the heart rate is of going into shock during this 24-hour follow-up period. Well, what you'd have to do to get some sort of ROC measure of how well this would predict for patients not used in this study you would need to pick a specific time in that period to look at. Does that make sense? So let's say at 12 hours, you know, we measured heart rate at that time, you know, you might look at some profile of the heart rate in the preceding time, like the average heart rate up until that time or something, and look at the discrimination between those who go into shock by that time versus those who don't. And you would then calibrate it based on whatever measure of heart rate over time up until that point, the average or the variation or whatever. So I guess what I'm saying is it's complicated because of this element of time, but yes, you can actually get measurements of how well this model predicts outcomes at the individual level at specific time points in a follow-up period. Does that make sense?
Yes, thank you so much, John. Yes.
Yep. So we have another question from Venkat, who
Yes.
says that since IRR is also used in Poisson regression, should we just restrict ourselves to using the term hazard ratios when we're doing a survival analysis? Because he feels that while watching his videos, you preferred IRR to hazard ratios.
Well, quite frankly, you know, some days I prefer hazard ratio, some days I was just in an incidence rate ratio mood when making the videos. But in all seriousness, I think we get too hung up on, especially for clinicians who are doing the hard work of making sense of the results and trying to implement things to make patients' lives better at the individual and at the population level. The distinction and differences in technical differences in these two quantities are irrelevant, absolutely irrelevant. They are the same thing conceptually. If you want to argue with some statisticians would argue with me and say it's important to take into account the slightly different nuances in how these are computed. This is what I was equivalating with a risk ratio, which is measured in a discrete period of time, and this is comparisons theoretically done instantaneously in time. But quite frankly, yeah, operationally, it's irrelevant in my opinion. That being said, if you do use another form of regression, and this is something I'd like to talk about briefly, is because some of you might say, John, well, you've sold us on this Cox regression, or you've pushed it hard, and it may be because you met Dr. Cox and you have not met Dr. Poisson. And that may be true, but it's a really legitimate question. Why does everyone use this, right? There's a lot of assumptions built in here. There's proportional hazards. And while it may seem nice that Cox completely deals with the element of time, because I kept saying, all we have to focus on is the predictors we choose, and Cox will deal with the relationship of risk over time, or hazard, if you want to call it that, or incidence. That also strips us of some of our investigative capabilities, right? If I am not allowed to weigh in and look at different possibilities and test different hypotheses about the shape of risk over time. Because Cox says, I'll deal with that, and all you have to focus on is your predictors of interest, but you have to grant me one big wish, which is that if I deal with time, you have to assume that the association between your outcome and predictors, the comparison is consistent over time. That's proportional hazard. Well, there are other approaches to survival that are different regression-wise and have different aspects. One of them that was mentioned here is Poisson. And Poisson and Cox are similar in spirit, but the time part of Poisson is not estimated automatically. We have to weigh in. So generally speaking, Poisson looks like this. We estimate the log incidence of an outcome or hazard colloquially. I don't, again, really that, I wouldn't worry about the distinction. And just like Cox, it's going to be a function of time, sorry for the plus predictors. But here's the thing, with Cox, it says, don't worry about the general shape of things over time. I'll handle that, I'll figure it out. With Poisson, we have to imbue our assumptions within this part. So if I, for example, want to assume that within any one group, the risk is constant over time and the groups differ depending on what group we're in, I could not put in anything for time and there'd just be one overall intercept that doesn't depend on time that would give this baseline risk over time. At any given time, this is where we start in a group with all x is equal to 0 and we go up or down accordingly. And it's always the same amount. If I want to see or estimate this under the assumption that the relationship between risk on the log scale and time is linear in nature, in other words, if I'm looking at time and log scale, that the risk is either constantly increasing with each of the groups I have or constantly decreasing, then I can put in a linear term for time and then have all of my other predictors. If I, again, that if I want to break time into discrete intervals and put indicators for them, I can do that. And I can test different models against each other to see if there's evidence for one type of association versus another. But I am driving this. Does that make sense? I am making the decisions about how this happens in Poisson. And it's possible that I will make the wrong decision. I will force the association with time to be, everything else to be estimated as if it's constant when really it jumps all over the place over time. Or I will force it to be linear when it really is parabolic or something of that nature. And I know I'm talking about a lot of things here. And so that's, I have more control in Poisson, but the chances of messing up are greater because I can mismodel this. And you might say, well, what are the consequences of that? And it turns out if I, just like with Cox, I can then translate any Poisson regression back into an estimated survival curve for different groups over time. And if I misspecify the time element, I will misestimate the survival over time. So the trade-off with Cox is, hey, I give up my rights to handle time to you, Dr. Cox, but Cox will fit something appropriate given the data itself. With Poisson and other methods, I choose how the story is going to unfold, but I may incorrectly do that. Does that make sense?
Yes, sir. Yes. Thank you.
Thank you, John. I think most of the other participants may not even have heard of a Poisson distribution or a Poisson regression. And most of us are never going to use Poisson regression in our careers. So apart from Venkat, if others did not understand a word of Poisson regression, don't fret and don't be disheartened.
Yeah, please don't be disheartened. I'm sorry. I just wanted to put this out there
Absolutely.
for those of you who have seen other types. Thank you, Amir. Thank you all. Cheers.
Thank you, John. And we didn't see your cat.
You may have heard her, but yeah, she got distracted by something else.
Yeah,
You know how
something better than statistics.
Right, she likes Poisson regression, so she, you know, what can I say? Because Poisson means fish in French, right? So it's, you know, it's cats like fish. So there we go. Thank you all.
Thank you. Thank you so much.